start the meeting.
Good evening all. Welcome you all to the 12th edition of the Ophthalmology PG Classroom. Every Wednesday we have been holding this, and 1 week we will do a case and a case-based dissection and evaluation of that particular case. And the next week we do usually some investigations. This time we have with us none other than Professor Dr. Dinesh Talwar. Dr. Dinesh Talwar is my teacher. He was professor at All India Institute of Medical Sciences before he moved out to Center for Sight and Apollo Hospitals, now full-time in Center for Sight in New Delhi. He is an avid teacher, a passionate teacher, and his breakdown of statistics of any study would actually send shivers down the spine of the people who actually wrote those papers, be it randomized control trials of the world or be it whatever. So his analytical ability is what makes Dr. Dinesh Talwar so special. Welcome you, sir, wholeheartedly to this session.
Thank you.
We have with us today the postgraduates of Amrita Institute of Medical Sciences, and we will start the retina spotters today. Next week, we will have a case presentation. All right. So let us start the retina spotters. Can we have the slides? Yes. Thanks. Yeah. Is it full screen? Can you make it full screen? Okay, yes, can you, sir, I will know all the people by name. So I will basically ask them initially, and then you can basically, compliment and tell further on that particular subject. Yes, can we have a diagnosis here? So the format that we will follow is, we will have a diagnosis, or we will have maybe 2 or 3 key findings of that particular picture, and then a probable diagnosis. And then we'll go to some theoretical aspects of it. Why did you make that diagnosis? What are the differential diagnoses like? Okay, so like that we will go. Okay, sir? Any? Okay. Okay.
You can reverse it also. You can say, what are the findings first?
Yeah. So, Yash, can we start with you?
Okay, sir.
Yeah.
So this is a clinical picture or color picture of the right eye of a patient. And sir, I'll just skip to the diagnosis.
You tell the findings. You tell the findings first. Yeah.
So the media appears clear. Optic disc, margins, and color looks normal. Margins are well defined. The color is normal with a cup to disc ratio of about 0.3 with healthy neuroretinal rim. Vessels over the disc look fine. There are a few microaneurysms along the vessels seen superiorly as well as inferiorly along the arcades. Coming to the macula, although a clinical examination with 90D would help us in diagnosing any macular edema if it is there, but seeing this photo, I can say that there is some sort of macular edema as the vessels are traveling a bit upwards and are looking a bit out of focus as compared to the vessels elsewhere around the macula. And there are a few hard exudates, a yellowish lesion suggestive of hard exudates around it. So with the given findings, it is looking like a diabetic retinopathy with the clinically significant macular edema.
Okay, Yash, where would the microaneurysm start?
Is that a complete diagnosis?
Sir,
like, what would you like to actually complete your diagnosis with?
Right eye, sir, grading of diabetic retinopathy, I would like to have more pictures actually.
No. With this picture, what is it that you would say? What is in your mind when you're saying I need more pictures to grade? What else are you talking about?
All the quadrants, looking at.
So what do you want to see in those quadrants?
More number of microaneurysms. If there is any cotton wool spots, hemorrhages, is there any?
Okay, so we are not going into that level. First thing is, from this level, what do you get?
So
it's non-proliferative diabetic. It's not retinopathy.
Yeah, it is not proliferative.
It's not diabetic retinopathy. It is non-proliferative diabetic.
Yes, sir. Definitely.
This picture is a non-proliferative diabetic. If there's a proliferative change somewhere else, we don't know.
Okay, sir. Yes, sir.
If you were given this as a patient, then you are expected to see all the quadrants.
Okay, sir.
And then your diagnosis would have to be in terms of non-proliferative retinopathy also, whether it is mild, moderate, or severe.
Yes, sir.
But if it is just this picture we are talking about, then you can only say non-proliferative diabetic retinopathy.
Yes, sir.
right?
Yes,
So
exactly.
that much. Can you make a diagnosis of macular edema from this picture?
Sir, as I said, that based on picture, which is basically a 2D analysis,
Which
only
means the question from a spotter pointer would be with a direct ophthalmoscope, that's a 2D image, just like this image. Would you be able to make out diabetic macular edema?
direct ophthalmoscope.
Yeah, same thing as this picture.
Yeah, direct ophthalmoscope I can.
So this is also the same thing.
Based on this image, I'm saying that the vessels elsewhere look pretty much focused, but around the macula, it is looking a bit not in focus. That means it is a bit elevated, and that is pointing towards some sort of a macular edema happening here, sir.
It is not actually not focus. Actually, what edema does is it makes the capillary network in that area less clear. Okay. So the grayness which is there of diabetic macular edema makes the capillary network which you normally see. Normally, what you're seeing is a net, the capillary net of the retina.
Yes,
and
sir.
you're seeing the choroid through that. So you're able to see actually the elements of the net, and then you see the choroid behind that, the reflex from there. Area which has an edema, the net is not seen. That is why it's gray. That is why it's not out of focus. It's within focus in that sense, but it's grayish. It's a little grayish looking, and the network, the capillary network, is less clearly seen. That gives you the idea that you're dealing with macular edema.
Edema, yes, sir.
Okay. Does the hard exudate mean macular edema?
Hard exudates can point towards macular edema, but not necessarily that it is always associated with edema.
So where did they come from? So what do they point to?
If the macular edema has resolved or edema has resolved, then two hard exudates can persist for a while.
Yeah. So basically,
they're a sign of edema.
Yeah. So it's what we call a tombstone.
Yes.
It indicates that at some point of time here there was edema. Now it may or may not be there. So it is only a pointer that sometime there has been edema in this area. At the moment, whether it's there or not, you need to confirm with a 90D, a stereoptic examination, and you get your idea from this. Can a fluorescein angiography leak confirm for you clinically significant macular edema?
There'll be leaks, capillary leaks, sir.
Yeah. So does that confirm? Supposing you had this, and I said, okay, I'll give you a fluorescein angiography picture, and it shows some leaks. So does that confirm for you that this is a clinically significant diabetic macular edema? Likely to be. No. Fluorescein dye-leak maculopathy is a known entity. So you can have leaks on fluorescein angiography, but there may not be clinically significant. See, this was a trick question. I said, I didn't say maculopathy. I said clinically significant diabetic macular edema. The diagnosis of clinically significant macular edema means the edema has to be there on your stereoptic.
500 microns.
Yeah, it has to be, there has to be thickening, right?
Yes, sir.
So and fluorescein dye-leak maculopathy can be without thickening. Okay. Yes. So fluorescein angiography is not the way to diagnose clinically significant diabetes. It is only a way to decide whether you want to laser or something. If you want to pick up where the leaks are coming from, then it's useful.
Yes.
But one thing you just said while I was talking, clinically significant macular edema is within 500. You said something like that. What did you say?
Retinal thickening within 500 microns.
Okay.
Of the macula, center of the macula.
Okay.
Then presence of hard exudates with the retinal thickening within 500 microns.
Yeah.
If there is hard exudates and edema outside this 500 micron, but part of hard exudates are lying inside the 500 microns of the center of the macula, then also.
No. Now you're getting a little confused in this.
That criterion is?
See, the problem is nobody talks about clinically significant macular edema, so people forget over time. Clinically significant macular edema comes in 3 grades. The severest grade is involving the macular center, the foveal center. Okay?
Yes, sir.
The second grade is hard exudate within 500 micron.
Yes, sir.
Okay? And adjacent macular, adjacent retinal thickness. Okay, that means center may not be involved.
Yeah.
And the third category is area of retinal thickening more than 1 disc area in size. Area, not diameter.
Okay.
More than 1 disc area in size within 1 disc diameter of the foveal center. That means
any part of which is lying 1 disc diameter
within 1 disc diameter. Okay. So that means you can have 6/6 vision and clinically significant macular edema.
Macular edema.
Okay.
Yes,
So
sir.
these are the 3 categories, right?
Yes,
So
sir.
now what you're dealing with is center involving diabetic macular edema.
Yes, sir.
Okay. So where the center is involved. Is center involving diabetic macular edema amenable to focal laser?
Yeah, in focal laser, better to inject, sir.
No.
As in,
I'm asking very specific question. Is center involving diabetic macular edema amenable to focal macular laser?
no, sir.
Okay. You see this area over here, this is hard exudate here.
Yes, sir.
Actually, if you look at it, this area, you can't see my pointer, no?
This area, sir.
Yeah, this area, and above this, there's a microaneurysm.
Yes, sir.
And this whole area seems to have a little grayish, this thing.
Yes, sir.
Now, supposing this was going into the macula.
Okay, draining into the macula.
No, this whole area had edema up to the macula, up to the center. The leak was coming from here.
Top.
Huh?
Yes,
Could
sir.
you laser it? Could you laser it then, this microaneurysm temporally?
That would be some sort of a grid laser pattern.
No, why?
Just
One
the top half,
microaneurysm.
just the top area, this side.
No, I'm talking of this macular, just one microaneurysm over there. Maybe another one on this side.
Yes, sir.
2 microaneurysms. Okay, another one possibly in the middle over here. 3 microaneurysms. Why do you need a grid?
Okay, focal laser over here. Okay.
Focal laser. Can you do focal laser for this area? Is it safe to do focal laser for this area?
It will be still lying within the center,
How?
30 degrees.
Central?
30 degrees.
Okay, what is the limit given in the ETDRS regarding the safe limit for initial focal macular laser?
How far away from the center of the fovea?
Can you do laser?
Have to go through that.
350.
500 micron.
500.
Okay. Though at that time we had no other treatment, so in a retreatment we could even go up to 200 micron, but leave the 200 micron. 500 micron is what ETDRS says you can go. Now let's say even this is too much. What about half this diameter? That's safe, 750 micron. Ask Gopal whether he thinks 750 micron away from the fovea is safe. Is 1000
Yeah.
micron safe?
Yeah, if you
Anything
put
within
grade 2
the-
burns or something
You're
like
putting
that, very
one
small 50
if
microns.
you're putting burns 1000 micron from the foveal center. You're
It's
safe?
not completely safe, but it is okay. I think
safe?
acceptable.
Now,
Acceptable.
if you look at these points, these are more than 1000 micron from the foveal center. They're actually more than 1 disc diameter from the foveal center.
1500 meters or,
Right?
microns away.
They're absolutely safe. A 100 micron spot cannot spread into the fovea from here. It can't cause any foveal effect. Right? Now, this area is amenable to focal macular laser, but it is a center involving macular edema. Okay, so you can have a center involving diabetic macular edema where the origin of the leak may be more than 500 microns from the foveal center, and which is then amenable to laser. This is important when you go into practice, because tomorrow you will have patients who can't afford They can't keep on giving you injections for a lesion which is 1000 micron away. Okay.
Yes, sir.
Okay. Okay. So Gopal.
Sir, so based on what Dr. Dinesh Talwar has said right now, can you just classify the diabetic retinopathy, non-proliferative and proliferative? Can you just tell the grading, Mira? Can you tell us? Grading of diabetic retinopathy.
Diabetic retinopathy can be divided into mild, non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. And non-proliferative diabetic retinopathy can again be divided into mild non-proliferative diabetic retinopathy, in which there will be only microaneurysms. Few microaneurysms will be there. In moderate non-proliferative diabetic retinopathy, there will be microaneurysms, which is more in number than mild, and there can be the presence of any hard exudates, cotton wool spots. Also, it may or may not be present. Moving on to the severe non-proliferative diabetic.
No, 1 second. Could you clarify that? Where? So huge football field over there. You know, I have a problem covering the entire fundus in one go. So where are you talking about?
Pole, sir, in the posterior pole, sir.
So where in the posterior? Supposing I say the patient had retinal hemorrhages in all the quadrants. Now, what is it? Is this mild, moderate, severe?
Sir, if there is in all 4 quadrants, it will be severe, sir.
Yeah, so that's so you've not categorized, no? When will it be less than severe? If it's less than, if it's
Less
1 or
than
2 quadrants,
it will be moderate NPDR, sir. If it is involving more than 4 quadrants, that is in severe NPDR, we have a 4-to-1 rule. Whereas in there is more than 20 hemorrhages in 4 quadrants, and in 2 quadrants there will be venous bleeding, and in 1 quadrant there must intraretinal microvascular abnormality, sir. That comes to severe NPDR.
okay.
And coming to PDR, there will be neovascularization of the disc. Neovascularization.
We will in the future it will come to that. Okay, can we go to the next slide, please? And one more thing, from what Dr. Talwar had said, we have a treatment entity called focal macular laser in a center involving diabetic macular edema. Currently the classification of diabetic macular edema itself has changed into center involving and non-center involving after the advent of OCT. What we were doing without an OCT was what Dr. Sir had told, the 3 criteria for clinically significant macular edema. And at that point of time, we were basically having laser only. So laser, if there were leaking microaneurysms, which are 500 microns away from the center of the fovea, we would do just focal laser to those. We would use a grade 2 burn and just make sure that the microaneurysm which is leaking will blanch. That is all. And if you did not have microaneurysms which were leaking, but there was a lot of edema in those regions, and you could see that there is a lot of edema, those were the areas which we would put a modified grid laser. Not a total grid, but a modified grid laser, which are grade 2 burns, spaced 1 burn width apart, about 50 microns in size, maybe 20 to 25 burns you would put in the areas of edema, again beyond 500 microns of the center of the fovea. That was the treatment at that point of time. Currently, if there is diabetic macular edema involving the center, first thought process would be to inject. And yes, if a microaneurysm is there, like sir is showing in this particular picture, it is away from the fovea. And if we have more than 350, 400 microns and the visual acuity is below 6/9, we may safely consider laser of that microaneurysm, which is very away from the center of the fovea, before you actually go in for an injection. It's possible. But after a laser, probably you'll have to wait for maybe a couple of months to see the results and then only decide on the further treatment. Sir, we'll go to the next slide.
Yeah, go ahead.
Sure. Yeah. Can we go to the next slide? Okay. This would be more of a, there would be no prices for guessing this one. This is clinically significant macular edema here. A lot of hard exudates. Probably there is a lot of thickening as well. This many hard exudates definitely will require that there are there is usually thickening associated with this. Nia, can you tell us how would you approach this case? What would be your first investigation? How would you go about looking at this case? And
first of all, tell me, why is this not
AMD?
The exudative form of polypoidal choroidal vasculopathy?
Because, sir, there are other changes like multiple dot and blot hemorrhages we can see in almost all quadrants. So most
And
along with hard exudates and microaneurysms also we can see, along with some amount of cotton wool spots inferiorly also we can see. So totally it looks like a picture of diabetic retinopathy.
And
clinically significant macular edema.
So there are a lot of microaneurysms and other features of diabetic. What would be the feature of PCV, which is not there here? Clinically, how would PCV appear like polypoidal choroidal vasculopathy? PED. There may be PEDs, yes, but typically there will be a orangish
lesion, and it will be single. Most probably it will be single.
No, it could be more than one, but you'll have orangish kind of nodules.
Okay, so here always look for microaneurysms, which is central to an area where there is a ring of exudates. So, and they will be slightly leaky on fluorescent angiography. Okay. Yeah. So Nia, can you tell us, how will you go about it?
In this patient, I would like to proceed with doing some investigations. Systemically, I would like to know about the glycemic control status of the patient, and as ophthalmologically, I want to do OCT macula of the patient, optical coherence tomography macula of the patient, as well as I would like to proceed with fundus fluorescein angiography to know whether any new vessels present, to know whether any new vessels are there.
Sir?
Yeah. So, again, in this case also the same thing will apply. Here you have to be careful about the lipid profile of the patient. A person with so much exudation, one thing you have to be worried about is whether his lipid profile is deranged. Okay. If the lipid profile is deranged, would you still go ahead with all your treatments? Would you like to do something else? Is there anything else you would do if the patient has, I mean, you would be doing your eye treatment, but is there anything else? Would you ask the patient to go to a physician to get some lipid profile treatment done?
Yes, sir.
So basically a patient who's got dyslipidemia needs to have treatment started for that. A patient who's also got uncontrolled hyperglycemia can have high triglycerides. So that's another thing. So you want those to be controlled too. I've already told you that even if the patient has on your fluorescein angiography, one, you found out whether there was neovascularization. Second, you also get to know whether there are multiple focal areas which you can laser. But even to laser that, you'll first give anti-VEGF treatment, bring down the edema, and then you will consider the ones which are left as leaking spots, whether you want to do laser for them. And then subsequently, again, you will go back to anti-VEGF agents. What do you expect to be the vision of this patient?
Since the hard exudates are at the fovea, the vision will be less.
So do you expect him to have, say, 6/9, 6/12 vision?
No, sir. It will be about less than 6/36.
Okay. So if you now in this particular patient, what would be your anti-VEGF drug of choice?
According to the
According to whatever information is available to you.
According to
We are going, actually, this is not being treated as a spotter. Yeah, spotter, we were supposed to stop you once you've diagnosed. This is being
We are going a little beyond spotter. Yeah.
Huh?
We are going a little beyond spotter.
Yeah,
it's
this
okay.
is beyond spotter. So if you want to stop it,
that means Nia has passed. Now we are going to give you distinction.
We are trying to, we're trying to go to the distinction point.
Okay. So it's since this is a hard X-ray, it's correct the macula. I would like to give aflibercept if the patient is financially sound to take it.
Okay. So good. So you can say the decision regarding treatment is often economic, but if it was only a scientific decision, then aflibercept is the drug of choice for treatment of patients with poorer vision. Is the anti-VEGF of choice for patients with poorer vision.
What is poorer vision?
Poor vision is less than?
No, I'm not asking you, sir.
No, you're asking me or asking her?
No, I am asking her. What is poor vision in aflibercept?
What is the cutoff which has been taken for that?
6/30.
Okay, 6/12, 20/40.
It's less than 6/12. Okay. Though, of course, the lower the vision, the more the advantage of aflibercept over the other drugs. Okay.
Okay. So.
One thing, Gopal, may I? I was keeping quiet. I wanted about the 4-to-1 rule because I see that lot of garbad is there in this 4-to-1 rule being quoted. So may I noted this down. It's actually part of the lecture and it's sometimes difficult to remember also. May I?
Sure, sir. You want to share your screen?
No, it's okay. I can share it from here. Severe NPDR, the diagnosis by how it comes to 4-to-1 is severe NPDR is severe. That means intraretinal hemorrhages and microaneurysms in 4 quadrants.
4 quadrants.
All 4 quadrants. Okay. What are these 4 quadrants? These are 4 ETDRS fields. Okay. One field is above the temporal arcade, above the superior arcade. One is below the superior arcade. One is nasal to the disc, but above the horizontal meridian. Again, upper nasal and then lower nasal. And these are all 30-degree fields.
No, sir, but the ETDRS had 7 fields. No?
7 fields. No? These are the 4 fields which are used.
No, but it had 7.
The point is, okay, see, the thing is, there are 7 fields, but 2 of them are the macular fields only.
Okay.
The first 3 fields are macular fields. One is centered on the disc.
You're talking about
one is centered on the fovea, and one is centered on the edge of the fovea.
Yeah.
So वो तो center में आ गया ना. So all those are actually within the central retina only. So it is the 4 quadrants would mean these 4 quadrants. Okay. So if it's there in this, if it's in the macula, it has no meaning. Supposing you say 3 quadrants of the macula, they have no value. This is the upper, lower on both sides, which are important. Those are the 4 ETDRS fields being considered for this diagnosis. Okay. And now to all the postgraduates, I am telling you something, you need to go and confirm it. I don't want you to take anything on face value, because this is something where there is controversy. So you should always check yourself also. But the basic thing is, so now these 4 quadrants, we're talking of hemorrhages in each, hemorrhages and microaneurysm in each of these 4 quadrants. Or it's not and, it is or venous bleeding in 2 quadrants. So either this, that means now the hemorrhages may be less, they may be less than severe, but if there is venous bleeding in 2 quadrants, then it is again severe NPDR. And or, now the third or is irmas in 1 quadrant. Okay. This is the definition of severe NPDR. 4 retinal hemorrhages or microaneurysms two
Venous bleeding.
venous bleeding, or one IRMA, or one of these three things. Very severe NPDR is severe intraretinal hemorrhages and microaneurysms in all four quadrants, plus venous bleeding in two quadrants. Plus, now this is now plus, either venous bleeding in two quadrants and or IRMAs in one quadrant. So it is one of these two must be there. So that means now two of the three things are there. Severe hemorrhages though is an essential part of the whole thing, right? But along with that, if in two quadrants you have bleeding, venous bleeding, and or in one quadrant you have IRMA. So you can have bleeding and in two quadrants and IRMAs, or you can have only bleeding or only IRMAs. Along with these four, you still have very severe NPDR. Okay. The amazing thing is soft exudates don't come into this diagnosis. Soft exudates is, though soft exudates in all quadrants would actually signify clinically to me very severe NPDR, but they are not a part of this diagnostic classification.
TDRS classification, it is not a part.
Okay. Why is it important? What is the importance of this differentiation? Why does it matter to me whether we are dealing with severe or less than severe? Moderate doesn't matter to me. Mild doesn't matter to me. Why does severe matter to me? Anyone wants to guess?
What is the progression of severe non-proliferative diabetic retinopathy? Anybody? How many people would move to proliferative in a year or 5 years?
15%.
Okay, good. Now, basically, patients of severe NPDR, they have a chance of progressing to PDR in 52% of cases. In 52% of cases. And to high-risk PDR. Okay, that definition is separate one. You will discuss it later on. 15%, 1-5. This is severe NPDR. The chance of going to PDR is 50%, chance of 52% really, and 15% for high-risk PDR. The chance of very severe NPDR going to PDR is 75% in 1 year.
In 1 year. That is very
in 1 year.
In 1 year.
And we're talking of 1 year. And progression to high-risk PDR is 45%. This is for very severe NPDR.
So
Okay.
that is why at the time when the patient reaches severe or very severe NPDR, according to the clinician's discretion, you can consider a laser panretinal photocoagulation, because very high chances of moving into PDR and PDR with high risk characteristics. Is that right, sir?
Yeah. Yeah. So actually the ETDRS was a very ambiguous conclusion. They left it to the surgeons, to the ophthalmologists, by saying you must not wait once you have high risk PDR, but you may do if it is very severe NPDR, if the patient cannot come for follow-up, or if you think patient is not this thing. But at this stage, you must definitely do it. So they didn't say it has to be done at very severe NPDR, but they left the way out. If it's one-eyed, patient has other comorbidities, patient may not come for follow-up, for whatever reason, then you can do that. So you have a reason to say, I don't think any patient will not come for follow-up, so I did it. Okay.
I just wanted to ask two more questions in this before we move to the next slide.
Yeah.
Gargi, can you tell me what are the causes of hard exudates? These are hard exudates. What are the causes of hard exudates?
She speaks very slowly. Yeah? I can't hear her. You're not audible.
Maybe
Or am I losing the...
mic.
Gopal, am I audible?
Yes, sir, you are audible. You are completely audible. Okay, so when Gargi is fixing her mic, can somebody else also answer the question? Lisa? Causes of hard exudates.
Sir, hard exudates are caused by the chronic localized retinal edema, and it is composed of lipoproteins.
Don't use the term localized. Just say edema, because it can be diffuse also.
Okay, and it occurs as a result of long-standing edema. Actually, it is seen between the adjacent between the junction of edematous and non-edematous area.
No, that's not true.
Okay.
It's not at the junction of what is a hard exudate? What is it composed of?
It is composed of lipoproteins, sir, and it
lipid. This is
lipid-filled macrophages also.
Right. So this is lipid. Macrophages will engulf lipid later on. Okay. And why does the lipid come there? Because there's plasma. What is retinal edema? It's fluid which is come into the extracellular spaces. So when it comes into the extracellular spaces, now when it's reabsorbed, the lipids are now going to get absorbed. So they get stuck there. And those lipids will then get engulfed with macrophages before they can go. But that's what that lipid is what is there as hard exudates. And it can be engulfed with macrophages. It can sometimes get fibrosed also. You can get fibrosis there also. But basically, the hard exudate is lipid material, which is left there as when the macular edema absorbs. But because macular edema is occurring and resolving, so you see both together. Otherwise, we discussed macular edema may not be there and hard exudate may be there when all the edema gets absorbed and it doesn't come back. Okay. Anything you want to add, Gopal?
Yes, no, sir. This is quite okay. I was thinking that you could have BRVO or tributary vein occlusion, or AMD, radiation retinopathy, Coats disease. These are some of the causes of hard exudates.
Any condition that causes edema, any causes that causes macular edema will predispose to this. Is there any condition you know that in which very commonly you get retinal edema but don't get hard exudates? Any very common condition?
Which occurs in some tense individuals.
One condition. No, even before that. What about? There is a particular thing which is, you get something like 2 million patients who could be treated of a particular condition, and many of them get macular edema, which goes away without causing any hard exudate.
Central serous retinopathy.
Huh?
Central serous retinopathy.
But central serous retinopathy is the hint that Gopal was giving you, and it is correct. But what about a condition in which some 3 million procedures are done every year? Many of those patients get macular edema.
CME, post-operative CME.
Yes. Okay. They don't get macular edema. They don't get hard exudate. Okay.
Okay, one more question I want to ask. So Dr. Talwar was telling us that soft exudates are not part of this particular classification system at all. So what is the significance of soft exudates, especially a lot of soft exudates in a diabetic retinopathy?
It will signify more of ischemia.
So where are you expecting soft exudates to occur? Where the ischemia is micro. Diabetic edema, diabetic retinopathy causes widespread. When would you expect microinfarcts? What is a soft exudate? A microinfarct, isn't it?
Yes, sir.
A nerve fiber layer microinfarct.
Yes, sir.
When would you expect lots of microinfarcts to occur?
Hypertension.
More of venous occlusions. It will also be like if there are soft exudates only in all the 4 quadrants, then it can also be a CRVO.
Can it be something without a CRVO?
Hypertension.
Yes.
Hypertensive retinopathy.
Hypertensive retinopathy is the first thing that I would think. If there are too many soft exudates in a patient who has diabetic retinopathy, I would also check for associated hypertensive retinopathy. Gopal, you wanted to add something else?
No, sir. I mean, I have seen that a lot of foot infection patients have multiple soft exudates, then renal failure patients, accelerated hypertension, and obviously, yes, combined hypertensive plus diabetic retinopathy.
Okay.
Let's move on, sir.
No, that's
Next,
thank
please.
you.
We'll take this.
Meera.
Meera, you can take. We'll take.
Yes, sir.
Yeah.
So this is a fundus picture of the right eye. With disc, the media is slightly hazy.
You should
This-
say it's an overexposed fundus picture of the right eye.
Okay.
You know why? Because your diagnosis is going to get affected by this.
Oh, okay, sir. Okay, sir. This is overexposed picture of a fundus picture of a right eye. With the
Incidentally, that won't happen in the exam. Huh? This
yes,
is
sir.
only for this is only
Yeah.
this is only for the for because you're telling us, you can let us know that we've not given you a great picture. But otherwise, this will not this problem will not happen in the exam. There you'll have the patient.
Okay, sir.
Yeah, go ahead.
So disc is appearing normal. And the vessels arising from the disc is also looking normal. There is multiple neovascularization which can be seen on the near the superior arcade. We can see multiple neovascularization. That is fine tuft of vessels we can
Is
see.
it multiple or is it one only?
Sorry, neovascularization. Fine
Yeah.
tuft of vessels we
It
can
doesn't
see.
look like a very large neovascularization.
Neovascularization, yes.
So just say neovascularization. Why? Dekho, exam mein na, you have to play safe also. Okay. Nobody will ask you whether it is 1 or 2 when it's not 100% sure that the doctor, the consultant himself can make it out. So, but if you say, I think there are multiple, then he'll ask you, bata dusri kaun si hai? You know, where's the first, where's the second? You know? So you just say that there's a large neovascularization there in the upper temporal quadrant. Now go ahead.
There are multiple hard exudates just superior to the macula. And also we can see multiple, we can see pre-retinal hemorrhage, nasal, intronasal to the disc, nasal and intronasal to the disc.
Have you completed your hard exudate?
Hard exudates are seen.
Yeah. And
Temporarily.
within
At the
that
macula,
area,
yeah, at the macula.
aren't you seeing those microaneurysms there?
Yeah, microaneurysms are also present.
There are
near-
multiple microaneurysms. Do you also see that here, what previously was being shown, the grayness, here you can see very clearly that the area is gray.
Yes, sir, yes, sir.
So this clinically you can say that this is macular edema there,
Yes, sir.
right?
Yes, sir.
So you can say suggestive of macular edema. See, be very careful because when you make definitive terms, then they say, how are you sure? And then how can you be sure? So then, of course, unless you want to trap the examiner into bringing up the, asking you about stereoscopic examination, so then it's different. So if you want to lead the conversation that way, then you may be, you may be saying, okay, I'm sure this is macular edema, and says, why are you sure? You say, well, confirmation is only possible by 90D, but looking at this, I can tell you that. Okay. Yeah, now go ahead to your next feature. We're talking about something else after that, no? After the macular edema?
infranasal and as well as nasal to this disc, we can see intraretinal, we can see pre-retinal hemorrhages, sir.
Okay.
And also there are scattered blot hemorrhages in the superior quadrant, above the superior arteries. So this is suggestive of a proliferative diabetic retinopathy, sir.
Okay.
So that immediately brings in what are the stages of proliferative diabetic retinopathy. We had discussed something called high risk characteristics.
Yes.
Yeah. So what is high risk characteristics?
In case of high risk PDR, there will be neovascularization on or adjacent to the optic disc more than 1/3 of the disc diameter, or neovascularization of the disc more than 1/3 of the disc diameter with vitreous hemorrhage, or neovascularization elsewhere more than one disc area with vitreous hemorrhage or pre-retinal hemorrhage.
So this is what category?
High risk
High risk.
PDR.
What are the criteria met by this particular patient?
This
One
patient.
is, yeah,
Oh,
this patient.
this patient, there is neovascularization. Neovascularization elsewhere more than 1/3 of the disc diameter, and also there is pre-retinal hemorrhage.
So 1/3 of the disc diameter is used for
Half
what?
disc diameter. That is for NVD, sir, and neovascularization of disc, sir.
Yeah. So this is
Half disc
not
diameter.
NVD.
Yeah, this is NVD, sir.
Yeah. So this is,
Neovascularization with pre-retinal hemorrhage is there, sir.
yes.
Yeah, we
So
have
this is-
NVD as well as NVE, no?
The NVD is not so clear, no?
Okay.
Yeah, there is actually. You can see inferiorly, you see inferonasally. The net is there.
Even centrally, the net is there. I think so. And one more thing is there. NVD is defined as not just neovascularization at the disc, but neovascularization
Diameter around
one disc diameter within the disc.
Yeah,
is
that's
NVD.
what. So this comes in within that one disc diameter anyway it comes. The upper one is the neovascularization elsewhere. Supposing the disc neovascularization was not there, is it still NV high risk?
Sir, I didn't get you, sir.
Supposing there was no disc neovascularization. Okay.
Yeah, then also it's high risk, sir. There is neovascularization elsewhere with pre-retinal hemorrhage.
Yes. So the presence of the pre-retinal hemorrhage makes it a high risk.
Okay, so high risk characteristic is for what? What is the high risk for? And which study gave us the high risk characteristic? Is it diabetic retinopathy study, ETDRS, DRBS? Which study gave us the high risk characteristic? And can anybody define the high risk characteristic?
What is the high risk of? That is the question. What is the high risk of? High risk of what?
For vision.
Huh?
Or severe visual loss. Okay, so that brings
And
us
what
to
is
how
the
will you
definition
define
of severe vision
severe
loss?
visual loss? Mirror muted.
Huh?
Okay, so severe visual loss is, anybody can tell us?
Sir, if the visual acuity is less than 1/60, sir.
If the visual acuity is less than 1/60 for more than 2 visits which are 4 months apart.
Not 1/60 which is mentioned, it is 5/200. Right, sir? 5/200.
1.5/60. If you want to take it as 60, then it is 1.5/60. It is 1/40 actually.
Okay, sir.
Okay. So it's 1.5/60 in simple terms is how much vision? You don't make the patient go to 1.5 meters. So how would you check that this is 1.5 meters? What do you do? How do you check the vision? What do you do? If it's less than 3/60, how are you checking the vision?
Finger counting, no?
Yeah. So are you right? So if it's counting finger at 1.5 meters, right? Approximately it is 1.5 by 60. Okay. Are we okay?
Yes, sir.
Yes, sir.
Yeah, so severe visual loss is less than 1.5 by 60 on 2 visits, maybe 4 months apart. 2 consecutive visits, 4 months apart. All right. So
And you
which
know the
means-
reason for taking that was because they were doing the follow-ups at 4 months apart. It's just a practical this thing.
Okay, sir. I think should we move on, sir?
Yeah, go ahead.
Okay. Next slide.
And I think one homework for you could be, what is the chance of getting severe vision loss in high-risk PDR? That is so important. How much is the risk of getting severe vision loss? I can give you the figure, but I'm not giving it now, right now. Because I want a little homework to be also done in this so that you remember. And that is from the diabetic retinopathy study. And it's again reiterated in the ETDRS also. And if you guys can't get it, I will give you the
Next
study.
week. Next time when we continue.
I will give you the
study.
study. Yeah.
Yeah.
Okay.
So one more thing additional to that. So what is the risk of severe visual loss in a high risk characteristic is one, and number two, if you do panretinal photocoagulation, how much reduction of that risk is there? These are the two questions that we answered in. Yes. Okay.
Okay. Now we can give them some homework, no?
Yeah, sure.
This is a close knit group, no?
Yes.
So we can give
Very
them
close.
homework.
So what are the types of hemorrhages inside the eye? Who is taking this? Can we ask one of the first years to take? No, why are we moving on? No, let us move to the bleed.
Have we got that many photo? Are we going very slowly?
It's okay, sir. I think what we will do is we are doing justice to each picture. So time is at our hand. There is no problem. We'll stop at 8 today, and we will continue maybe. I mean, during the All India Ophthalmic Society meeting, we will not be having that. So maybe 2-3 weeks down the line, we will have the rest of the images. So we'll go 5 or 6 images at one time. No problem, sir.
Okay. And I think after today, I don't have that eye focus issue anyway.
Okay.
In case you want me, I mean.
We would be honored to have you online, sir. Yeah. So what are the types of hemorrhages? Yes, can you tell us? Intraocular hemorrhages.
Okay, so pre-retinal hemorrhage, intraretinal hemorrhage, subretinal hemorrhage, superficial hemorrhage. Pre-retinal, superficial hemorrhage, then intraretinal, then subretinal hemorrhage.
Okay. You could add a sub-ILM also.
Sub-ILM,
Part of pre-retinal hemorrhage.
Yes.
Okay. And retrohaloid, which is also pre-retinal.
Yes.
Retrohaloid or okay. So what is the importance of this retrohaloid hemorrhage in diabetic retinopathy?
Retrohaloid hemorrhage. Basically, this is again in case of a PDR with this kind of hemorrhage. We can do a hyalodectomy, laser hyalodectomy, and release this fluid.
Usually, no.
Usually.
A hyaloidotomy is more difficult in diabetic retinopathy as compared to a Valsalva's retinopathy or something like that, or even a Terson syndrome or something like that. Okay. So here it is a little more difficult because the hyaloid is very, very thick. The diabetic retinopathy hyaloid is very thick, and it may induce fibrosis. It may start fibrosis at that focal point, and that can cause later on traction retinal detachment as well. So hyaloidotomy is not a good alternative in diabetic retinopathy. What do you say, sir?
Yeah. I actually don't advocate hyaloidotomy in any case, personally.
Okay.
Because I believe dirtying the vitreous is worse than, because once you let the blood come into the vitreous, it's going to take months to go, even though it's inferiority, and the patient's going to get floaters and all. Whereas a subhyaloid hemorrhage or a retrohyaloid, if you want to call it, Once it goes away, it doesn't leave any residue. Of course, unless you have to do a surgery. So unless there is an urgent need for the patient to be visually rehabilitated, even in other conditions, I wouldn't do it.
So here in retrohaloid hemorrhage, then again, another feature is that usually all the blood on the surface of the retina very rapidly coagulates and clots. But here is one hemorrhage which will remain fluid. So behind the hyaloid, there are supposedly a lot of anti-clotting factors, which keeps it fluid. And so after you cut the hyaloid, this fluid you can just drain out very, very easily. And the characteristic feature is the boat-shaped inferior margin of the retrohaloid hemorrhage. Why would there be a boat shape?
Because of gravitational, the most dependent point would be inferiorly. That's why this boat shape.
So the hyaloid is not cleaved much in diabetic retinopathy.
How did you tell it was pre-retinal or retrohyaloid? How did you tell that? How did you make that?
Sir, it's pre-retinal because vessels are not visible. It's beneath the hemorrhage. That's why.
See, if you look carefully at the lower part, you can see it's blocking the vessels, and so you see the vessels below. So you can actually see the vessels below, and you can see that where the hemorrhage starts, the vessel gets cut off. That means whatever is there has to be above it.
Yes.
Right? So that is how you know. When the blood cuts off the vessel, it means it is pre-retinal. Right?
Yes, sir.
Now let me show you actually in this hemorrhage only, there is one area here. Look at this. Because this was a very, very shallow, a very thin layer of actually what is pre-retinal, but over here the blood vessel is hazily seen. Can you see that? I don't know whether you can see that.
Sir, are you talking about this area, sir?
No. Disc, just half a disc diameter below the disc. This, you see this? And you can see the vessel there.
Yes, sir. Here.
So this can confuse you that is this subretinal because the vessel is seen. But actually, if you follow it carefully, you will see it's cut off. And you'll see that if you follow the rest of it, then you know that it is above because it's cutting off in many of those areas. So it's just that wherever it's denser, it's cutting off fully. If it's not denser, it's not fully cutting off. But so this can also happen. It can confuse you. Somebody can confuse you also on this. But you have to talk about this part. Say this is very clear. The lower part that is denser and it's the vessel is below, and above that is the hemorrhage, because the hemorrhage is obliterating the vessel. Okay.
Yes, sir.
Okay. So we'll finish today's program by just the last question.
Fluid level.
Yes, you wanted to ask. Yeah, the upper level.
Yeah, fluid level is also seen.
Yeah.
That is also
pre-retinal. So that is also. So gravitational thing doesn't happen in a subretinal hemorrhage.
Sir, the doubt that I have regarding this patient is it pre-retinal with some subretinal hemorrhage? Because at areas like this, it's looking like a fresh bleed.
Yeah. So
and this is actually color of the blood is altered.
Yeah, because it's more blood, it's thicker blood, and it may be actually clotted. Part of it may be clotted. You see this? You see what this whitish thing is coming is actually a thickened vitreous space, posterior vitreous space. And this is definitely liquid. Over here, there may be a part which is either a very thick, it may not be clotted, or it may be a very thick hemorrhage, or there could be a clot formation in this part. So that is why it's giving this appearance. But the only place where the doubt of subretinal hemorrhage comes. See now, let's assume it was this dense, but this was subretinal. Okay. Then you would see the vessel on front of it, even darker than this.
Yes, sir.
Okay. But because you don't see that, this is again, because it is red. If it was subretinal, it is beneath the retina. It has a little more grayish tinge to it. So that also gives you a clue that no, this is part of the same pre-retinal hemorrhage. Okay. I think when he shows you the subretinal hemorrhages, it will become more clear.
Yeah.
Maybe you can show it if you have it, a subretinal hemorrhage. If you
Yes,
have
we
it,
have subretinal hemorrhage.
then you can just show him one subretinal hemorrhage so that.
I'll have to search for it just a minute.
Doesn't matter otherwise. Or otherwise it can come next time.
Yeah. You can see that the blood vessel is.
Yeah. Now in this you see you see this vessel. Now you see it's so dark, but there's a little grayishness to it, and you see the vessel above it.
Yes, and here also.
And along the whole course, right?
Yes.
So you know you're dealing with a subretinal.
Currently, what happens is sometimes you do an injection before you do the patient, you take the patient up for vitrectomy. And if the time gap between the injection and the surgery is a little prolonged and the patient has traction, there could be fibrous contraction and there could be subretinal hemorrhage in diabetic retinopathy.
Yeah. So
Other
you
than
could
that,
get a subretinal.
yeah. Other than that, the chances of a subretinal hemorrhage in diabetic retinopathy is a little less good.
Yeah.
Okay. So with this, can we, it's about 8 o'clock now. We will wind up today, sir.
Okay.
Next week, we will basically start with that vitreous hemorrhage. I mean, that pre-retinal hemorrhage itself. And we will go through the indications of vitrectomy and then move on to the rest of the cases.
Okay.
I thank
You're
you,
the boss.
sir. I thank you very much, sir. I mean, I thought that my children also have the privilege of hearing you from close quarters and learning from you, like I did.
Thank you. I hope it was worthwhile.
Yeah, yes, absolutely, sir. Thank you very much, sir.
Thank you so much.
Very much. Till we meet again. Probably next week is going to be, no show for us because we are all in All India Ophthalmic Society conference. The week after that would be a case presentation, I think, from Kottayam Medical College or some other medical college. I am not very sure. I know that better. And then after that, we will continue with this retina sport.
Okay.
Okay, sir. Thank you very much.
Thank you. I enjoyed myself.